going to get started and get underway. I think it's the type of event people may come and go, or maybe they had something else, they're going to join a little later, and that's perfectly fine. Good morning. My name's Donna Pettey. I'm the Director of Integration Research and Evaluation here at CMHA Ottawa. And I'm thrilled to be hosting this really great event this morning. And I just wanted to start things off by introducing our Executive Director, Tim Simboli, who's going to open things up for us. Morning, Tim.
Morning, Donna. Thanks very much. Good to see so many people here. This is great. So I won't take too long. Just a couple things I need to do as is our practice here at CMHA. We start with a land acknowledgement, and we recognize that the work that we do in fact, for everybody who's on a Zoom call, if you're within a couple of 100 miles of our offices at 311, you're probably sitting on the unceded and unsurrendered territory of the Anishinaabe Algonquin Nation. And I mean, long before there was recorded history, that the Algonquin Nation existed and lived on this land and took care of this land. And we as settlers and as settler organizations came along and sometimes in some very nefarious ways, we've occupied this land. And I think that it's something we need to recognize and something that we need to make sure that we make better and that we atone for. The other part of the practice of the land acknowledgement is that we actually we try to make sure that there's a commitment to the intents of doing the acknowledgement, and that we look for some kind of relevance. And today, I think that's probably a pretty easy thing to do. CMHA Ottawa exists to make things better for our clients, for our community, for society. So this is just one more on a list of things that we strive to make better is our relationships and our atonement for with our Indigenous peoples. The other thing about part of the process of truth and recognition is the seeking of truth. And this is a day where we're, if you think of it in some ways, we're actually seeking the truth today. The basis of research and evaluation is to find the truth in some kind of objective, not absolute way, because we know truth is not necessarily an absolute concept, but to find it as best we can. And I think to move into why we're holding this day, I think I'd like to maybe frame it as a really important step for not only CMHA, but for community-based agencies generally. I think the importance of community-based services in the healthcare system, in the mental health care system, in the addiction system has long been overlooked. And I think it's new territory in terms of research and evaluation. Community-based research is a concept that's been growing, I think, but really essential to the work that we do. It not only informs us and makes us better, which is what we should all be aiming to do, but it also brings credibility and respect to the services that we do. And quite frankly, the healthcare system in Canada, whether mental health or physical health, depends on a population that lives healthy lives. And that, I think, is what we try to do as community-based agencies. So this is a very important day for us, and I'm delighted to be able to do it. And I'm going to try to turn the tables around. I'm going to thank people first, and then we're going to get into it. I probably have to step off at some point. I'll be one of those people who quietly disappear from the screen. I have another meeting to go to, but I'd really like to thank the presenters that we've got, and I'd thank them for their hard work and for the effort that they put into this and their willingness to share. I'd really like to thank them for their curiosity. For the idea that there's something out there, if we can kind of just dig away at it, we'll find something. That drives researchers, that drives research and evaluation in my mind. So I'd like to thank them profoundly for doing this. It was kind of awe-inspiring to find out when Donna said, you know, we do a lot of things. Maybe we should get everybody together and talk about this. I'm busy kind of focusing on my work and my life. And I went, well, what do you mean? What's out there? And she started to talk about it. And I was kind of blown away by the number of presentations. And I think you're going to be blown away by the number of presentations and the quality of work that's being done. And my last piece of appreciation is to those of you who are on the call, the audience members, if you would. And thank you for your curiosity, because it's the sharing of information and the finding the good work of other people and learning from that is really going to drive the work that we do in the profession that we're in. So lots of thanks for lots of people. I'm going to get out of the way and let things, I'll turn it back to Donna and we can get things going.
Thanks, Tim. I just wanted to introduce one more person this morning, John Sylvestre, who is here as one of our valued partners from the University of Ottawa, the Center for Research on Educational and Community Services, who we have a long-standing partnership with, relationship with. So just introduce John this morning. Hi, good morning, John.
Good morning, Donna, and hello to all, and thanks for inviting us to join you this morning. If I seem a bit nervous, it's because Donna reminded me that the last time I spoke at an event hosted by her, I was ushered off the stage with a loud buzzing sound because I'd gone a few seconds over time. And so Donna has assured me that's not going to happen today. But if I do seem a bit nervous, it's because I know what Donna's like as a host of these events. In any case, so yeah, John Sylvestre, I'm from the Center for Research on Educational and Community Services at the University of Ottawa. And our center's been around for well over 20 years now. And we have about 40 affiliated researchers, both in the faculties of social sciences and the Faculty of Education. And we really do a whole lot of research with a broad range of community partners. And so some of the topics that we've looked at include citizenship, child welfare, social innovations, and of course, community mental health and community mental health programs as a major focus of what we've done. Particular interest in questions related to housing and homelessness as well. But a major focus of what we do is program evaluation. So working with community partners to take a look at their programs to see how they're up and running and whether they're producing the outcomes that we would hope for them. And so a lot of the work that we've done with partners like Donna and CMHA Ottawa have been around looking at the various programs and how they're operating. We also, I should mention, have a new micro program in program evaluation. It's a 2-course option that people can study with courses in the evening. So people who might be returning students who are looking to upgrade their skills in program evaluation. And please contact me and we'd be happy to provide information on that. I know a number of folks at CMHA Ottawa have taken advantage of that training. As I was saying, we work with a wide range of partners in the local area. And our aim in doing this work is really, I see it as providing mutual benefit. What we do is really partner-driven research or partner-driven evaluation work in contrast to investigator-driven research. So we're not doing theoretically oriented or driven kinds of research. Often what we're trying to do is address issues or challenges or questions that come from our community partners. And the methods we use and the orientation we have is to provide back information that can be used by these community partners, by these organizations to have a fresh understanding of the work they do, but also to sort of seek ways to improve what we're doing. So very much what we're doing is we see is in the service of the needs of our community partners. And so, we're really focused on real world issues, real world concerns, and having, what we can consider actionable kinds of findings, findings from our work that you can actually sort of do something with, as opposed to simply, being intended for an academic audience. But I think there's also important benefits for us here at the university, one of which I think it just greatly enhances our work and makes it much more interesting to be working with a wide variety of partners, but also for the important training opportunities that it offers our students. You'll meet some of our students this morning. So they get, a valuable experience working with partners, understanding, what service delivery looks like in the field, honing consultation skills, honing applied research skills, and in this case, honing, really knowledge mobilization skills. How do we sort of share back the findings from our work as well? So very thankful for our partnership with CMHA Ottawa and the rest of our community partners. I'm very grateful for the opportunities you've provided our students over the years to have these experiences, and I'm looking forward to the presentations this morning. So thanks for having us here to join you.
Awesome. Thanks, John. So just a couple of things just to go through quickly. First of all, just a reminder for folks that we are recording this session. I know most of you, when you came on, it prompts people, but we just want people to be very aware of that, and if measure their comfort around that. The other thing, we just put up some of the titles that we're going to be going through today. We will be sharing a summary of the proceedings afterwards, and that will be sent out to all the folks who have registered for the day, and it'll also be available on our website as well. Each of the sessions are going to be between 10 and 15 minutes. If you have questions, please put them in the chat. We're monitoring the chat, and if there's time, the presenter will answer the question today. If not, we'll make every effort to have them answer it in a written form, and we'll include that in the proceedings as well along the way. And I promise there are no buzzers today. Right, John? And so that's great. So we're going to start things off then. And so our first speaker is Maryann Roebuck, and Maryann is actually completing her 2-year fellowship, postdoctoral fellowship at CMHA Ottawa, and in community mental health research. Now we're very pleased, as Maryann is a MITAC scholar, and MITAC's a nonprofit national research organization really that partners with universities and organizations such as ours, but it's a great way to build capacity to undertake community mental health research. So that might be a side thing if people want more information on that. So we'll start things off. Maryann's going to be presenting actually her doctoral research, and her title is The Working Alliance as a Mediator Between Fidelity to Strengths Model Case Management and Client Outcomes. So take it away, Maryann.
Thank you, Donna. Let me switch my slides and try to do this smoothly. Okay, can everyone see the Working Alliance title page there? Anyone?
Yeah.
Yep.
Yes,
Okay, thanks. Okay, so like Donna said, I'm sharing the findings from my doctorate. So I finished my doctorate just over a year ago, and the publications from this research, and then also the publications from the larger study that I'm speaking to, just came out a few months ago. So we thought this would be a good opportunity to share this work and continue to highlight it as we move forward. CMHA Ottawa played a very central role in this larger study, and as a result played a central role in contributing to the evidence base around mental health case management, strengths model case management, and the Working Alliance, which is what I'm speaking to. I'll just say on a personal note, this was a study I worked on. It was my introduction to CMHA Ottawa. So I started as a research assistant and research coordinator. And right away, I was welcomed and struck by the openness that the organization has to students, to community-based research, and to welcoming students to do program evaluation with the organization. So thanks, it's a privilege to be here and to speak to these findings. So like I said, this is part of a larger study. CMHA Ottawa, along with 6 other mental health organizations in Canada, implemented strengths model case management as part of this study. And then alongside the implementation of the model, there was an evaluation that was conducted to look at its effectiveness. So the research base around case management and intensive case management continues to grow, but there's a big need for more research in case management. And strengths model case management, it kind of gets a lot of gold stars as a good model of case management. It has the most studies around case management as an intervention, a specific intervention of case management. It has the most studies that support its effectiveness, so seeing change in people's lives. It also has a good structure to it, so it's well defined. It has tools and principles and guidelines around how to implement it. And then it also has a fidelity measure. So it has a way of measuring how closely local implementations of the model follow the original intention of, or the way that the developers of the model intended for it to be implemented. So that's important for evidence-based research. If we have studies that show that an intervention is effective, we want the local expressions of that intervention to look like the way the intervention was implemented that showed the effectiveness of it in research. So the broader study objectives were to link model fidelity with client change, so quality of life, hope, functioning, and community participation. And these aims were measured in 3 main ways. So there were fidelity assessments, like I mentioned. There were interviews with clients who received strengths model case management, and this was a longitudinal aspect to the study. And then there was a qualitative study component that looked at the experiences of the 7 organizations implementing the model. So implementing a new model takes a lot of work and effort, and it introduces a lot of change. So we documented that journey of all 7 organizations as they implemented this model for the first time. So I'll just say here that these were the 7, this is just a map of the 7 sites, but CMHA Ottawa was unique in several ways. The organization had the most clients participating in the study. And also the organization was unique in that because the focus is on people who are homeless or vulnerably housed, the sample within Ottawa was in different ways, they had higher needs. So kudos to the organization because they implemented the model with clients who met a lot of challenges and had complex needs along the way. 6 of the 7 organizations reached high fidelity or almost high fidelity throughout the course of the study, and they all started with different levels of fidelity to the model. Most organizations started without the structure of the intervention, so they would have started with low fidelity. And 1 organization dropped out of the study just because the timing of implementing the new intervention didn't work with the organization. By having the results of this study, of this site in the study, we had some variability in fidelity. So the broader study did not find a direct connection between fidelity to strengths model case management and client outcomes, sadly, partly because of the sample size, partly because fidelity was measured at the team level. So it was a bit challenging to get at a lot of variability in fidelity in the end. But that brings me to my findings around the Working Alliance. So the Working Alliance was measured in this study as well. So for my doctorate, I focused on this element in my analyses. the Working Alliance is pretty much the same concept as the Therapeutic Alliance in psychotherapy, but it's outside of psychotherapy. So in case management, we call it the Working Alliance. The research on the Therapeutic Alliance and its link with client outcomes is extremely well researched, but the link between the Working Alliance and outcomes outside of psychotherapy is not as well researched. So the Working Alliance consists of three things. It's the bond between a case manager and a client, the clarity of the goals of the intervention, so how much the case manager and client agree on the goals of the intervention, and then the agreement on the tasks to achieve those goals. So the level to which the case manager and the client are on the same page in the tasks of the intervention. And strengths model case management really fits well with that definition of Working Alliance. So one of the main principles of the model is that the worker-client relationship is primary and essential. And the tools used to implement the model shape this Working Alliance very naturally and very well as well. So for my analyses, I added the concept of the Working Alliance, or the measure of the Working Alliance, to the examination of the association between fidelity to the model and client outcomes. So I looked to see if fidelity to the model strengthened the Working Alliance or was associated with a strong Working Alliance, and if that strong Working Alliance was associated with positive client outcomes. And these are the findings that I produced. So my hypotheses were supported at after 9 months of receiving or being part of strengths model case management. Fidelity to the model was associated with strong Working Alliances, and the strong Working Alliances led to positive outcomes in quality of life and community functioning. And then at 18 months of being part of the intervention, the same results were found with quality of life on 2 measures and hope. And I'll just mention that I also conducted a qualitative study. So my quantitative analyses were on the larger sample of clients at all 7 sites. And then the qualitative study was following up to my findings quantitatively. And I interviewed 20 strengths model case management clients at CMHA Ottawa. So I got to have a lot of interesting conversations with clients about the value of the case management that they were receiving. And I'll just touch on one of the main themes. So when describing the case management that they were a part of, all of the 20 clients talked about the importance of goals in the intervention. The topic of goals came up naturally. I didn't probe for that conversation or that element of the interviews. And this was a really strong theme, so it really supported both the concept of the Working Alliance and how a strong Working Alliance means that there's agreement on goals of the intervention and tasks to achieve those goals. And then it also really reflected strengths model practice because of the centrality of the goals in the strengths model. So this is just a little taste of my findings. Also, where my quantitative analysis was limited to the measures of outcomes that we had, the conversations about change that clients experienced as a result of being part of case management was really rich in the qualitative findings. So we had conversations about all the different areas of their lives that clients experienced changed in, and the value of their case manager in bringing them along in that process or that journey. So just in conclusion, again, closely following the strengths model case management was associated with the strong Working Alliance. Strong Working Alliance then led to positive change in clients' lives, and goals as well as hope and strengths were key elements of the model. So I'll stop my presentation there to make sure we have time for others. Thanks, everyone.
Thanks, Maryann. And again, if folks have questions, they can put them in the chat, and Maryann, if we have time at the end, can answer, or we'll make sure we include them in the proceedings. So our second presentation is from Stéphanie Manoni-Millar, and Stéphanie's a PhD candidate in experimental psychology at the University of Ottawa, and Tim Simboli is her supervisor there. She's going to be presenting findings from our familiar faces evaluation, The title of the presentation is Mental Health and Substance Use Outcomes of Frequent Emergency Department Users Participating in a Community-Based Case Management Service. Stéphanie was a research assistant on this evaluation and is primarily presenting findings on behalf of John Samosh, who's also a PhD candidate in clinical psychology at the University of Ottawa. And Jonathan is focusing his doctoral research on the familiar faces study. Maybe next year we'll hear about that. And Stéphanie's presentation includes a video that Jonathan actually compiled of some of the findings. So welcome, Stéphanie.
Thank you. Yeah, so it's kind of, I split John's video, so it's kind of us sharing a presentation, but I'm just gonna share my screen here. Okay. So again, thank you, Donna, for the introduction and for CMHA for giving us the opportunity to share these findings. So I'm going to be presenting on behalf of John Samosh, but also more collectively, both on the preliminary quantitative and qualitative findings. If I play the video, can anyone hear it? No.
There's no sound. No.
No. Okay.
Is there something we can do to help, Stéphanie?
Did see anything now? I don't know which screen I'm sharing.
You're not sharing your screen, but we do see that you have your audio, like your video, your audio is on, so it should work this time.
Okay, perfect.
No. The audio doesn't work.
No. It doesn't work. Okay. Well, maybe we're gonna not have John's videos then.
Stephanie, it's Sam Rice here. You have your headphones in. I find you have to take your headphones out and disconnect, and then your audio comes from your computer, if that's okay with you.
I'll try it again then.
Emergency department users with mental
Can
health.
hear that?
Yeah, we hear.
Yeah, we can hear. Okay, perfect.
As you can see here, individuals with serious mental illness or problematic substance use who are looking for help face a complex maze of service options that would be difficult to navigate even at the best of times. As a result, many turn to the hospital emergency room, with mental health concerns representing 1/3 of all ER visits. Unfortunately, ERs are designed to assist acute physical needs, not the complex and chronic health and social needs of those with serious mental illness or problematic substance use, leading these individuals to repeatedly visit ERs over and over again to no avail. This increases ER wait times, costs taxpayers, and tragically fails to address mental health care needs in Canada. So what can be done?
So that was John providing a summary of kind of the overview of the need that Familiar Faces was responding to in our community, and just the overflux of clients using emergency departments for mental health needs. So as I'm sure a lot of you are familiar with the Familiar Faces program, it aims to support frequent emergency department users with mental health illnesses or problematic substance use and reduce their use of the emergency department, but also providing them with services that are in the community that are more able to be tailored to their needs and in order to best support them. So the purpose of this project was a program evaluation, and it was an outcome evaluation. So it was assessing the impact of familiar faces for its clients and investigating potential mechanisms for change and how to improve the program based on service providers and clients' needs and recommendations. So it's still an ongoing, almost completed project, but it has both quantitative and qualitative findings. From the quantitative side, it has structured interviews with 30 clients with doing a pre-test, post-test design. So this means that they completed a survey at baseline, so upon entry, and then at 6 months after they followed the transitional case management. And then there's also qualitative interviews. So these interviews were done with 15 clients of the program, as well as 2 focus groups with program staff. So in terms for the quantitative and statistical analyses, it was focused on total functioning, internalizing disorders, externalizing disorders, and substance use. And I found that clients who participated in the program at 6 months, there was significant improvement in overall functioning from baseline to follow-up, as well as significant improvements in symptoms of internalizing mental disorders from baseline to follow-up. There was no significant changes in symptoms of externalizing mental disorders, alcohol use, and substance use. And the implications for this show that familiar faces transitional case management short-term support was associated with improvement in patients' overall functioning. The frequency of emergency department users with mental illness or problematic substance use can benefit from the support of a combined system navigation. So that's the system navigation exploring community programs, as well as short-term case management service provided up to 6 months. And the benefits are most likely to be experienced in symptoms of internalizing mental disorders, such as anxiety and depression. The preliminary results suggest that CMHA Ottawa Familiar Faces program is effective in supporting frequent emergency department users, especially to reduce the use of emergency department and in order to address internalizing disorders. So clients with symptoms of substance use and externalizing mental disorders may potentially require more long-term supports in addition to this program to address their particular social and particular health needs. And then we're going to hear from Jonathan again with the qualitative findings.
Our qualitative outcome research into what makes this program work included interviews and focus groups with program staff and clients. Qualitative results highlighted that program clients reduced their use of ERs and experienced improved mental health symptoms, attributed to the following 3 important mechanisms of change that I will share with you today. First, the therapeutic relationship between program staff and clients was the most described mechanism of change. Many program clients interviewed reported believing that they would not be alive today were it not for the kindness, caring, and support of program staff in their time of need. Clients highlighted the importance of the openness and warmth of the professionalism that they received in this program as being notably therapeutic in and of itself. Second, staff and clients reported the importance of the program's vast awareness of and connections to many other supportive community organizations and resources as another key mechanism of change. This included housing supports, employment training, psychiatry consults, addictions counseling, and beyond. With these connections to more relevant community-based services for program clients, they no longer needed to return to ERs, as their needs were met more effectively elsewhere. Third, and finally, staff and clients noted the importance of the flexibility of this program in supporting clients. While the program does have general guidelines regarding how to best assist clients, the frequency and intensity of meetings, timelines for the duration of the service, and so on, these could be reasonably amended based on client need in the moment to be as effective and efficient as possible. Staff appreciated this flexibility so they could assist clients as best as possible, and clients appreciated this flexibility, meeting them where they are at to provide support that works for them now and not just under the most ideal of circumstances, because one size does not fit all in mental health care. So in conclusion, as we aim to assist those in Canada with mental illness or problematic substance use on their journey along the road to recovery, it is important to remember the necessity and relevance of 1, the therapeutic relationship, 2, building strong connections with a diversity of community-based resources, and 3, taking a flexible stance towards the provision of our interventions. Thank you.
So that was it's a short presentation. It's a short snapshot of what the program evaluation and the outcome evaluation is completing with familiar faces. There's still some work to be done. I believe that they still have to they're still obtaining data from ICES in regards to client health card data on how many times people are still using the emergency department. So more final quantitative findings will be, and more final qualitative findings will be coming up shortly within hopefully the next year. But overall, the Familiar Faces program and CMHA Ottawa is providing a helpful service, bolstering a strong therapeutic relationship fostered by program staff, and the connections with the broad community services and supports really provide an extreme benefit to the clients in terms of improvement and being able to access services that are attracting like their specific and personal needs. So I'm happy to answer any questions, but I believe, Donna, we said that you said you're going to do them at the end? Or?
I think if people would just put them in the chat if they had a question, and we can either do them at the end, or there doesn't seem to be one right now that I can see. Although that's not, oh, are you, oh, it's just saying you're all stars. Sounds like it's a bit of a fan club, I think. So thank you. And if people have more questions, we can put them in, and Stéphanie, if you see them, you can respond, or we'll put them in the proceedings. Okay. And I really felt like Jonathan was here.
I tried to make it that way.
That was awesome. Thanks so much. It's so interesting that the therapeutic relationship that Maryann was talking about, coincidence, also shows up in the Familiar Faces, a totally different service. So really reiterates the importance of that. No surprise probably to most people here. Okay, so great. Thanks, Steph. So our third presentation is Kimberly Turner, and Kimberly is a clinical psychology PhD candidate at the University of Ottawa, and John Sylvestre is her supervisor. She's presenting findings of a study we initiated with the university early on in the COVID-19 pandemic. So I mean like a month in kind of thing. I remember very clearly. Her presentation is called A Study of the Delivery of Telemental Health Services to People with Severe and Persistent Mental Illness with a History of Homelessness. So welcome, Kimberly.
Hi, everyone. Just give me a second to share my screen here. Whoops. Okay, does everybody see my presentation? Seeing some nods, perfect. All right, yeah, no, so thank you so much for the introduction, Donna. And as Donna mentioned, so I'm presenting the results from an evaluation looking at CMHA Ottawa's delivery of telemental health case management services for people with severe and persistent mental illness and a history of homelessness that they implemented in response to the COVID-19 pandemic that I worked on with a wonderful evaluation team who is listed here. Some of you are present today, so hi. Yeah, and so I'm going to start out with kind of a brief overview of the initiatives that were put in place by CMHA Ottawa that we evaluated, and then touch on our evaluation goals and our methods. But I want to spend the majority of the time today focused on our findings and our recommendations. And so obviously the COVID-19 pandemic and the resulting public health restrictions just had a huge impact on the delivery of community mental health services and really necessitated shifting some of those case management services to telemental health in order to just maintain that continuity of services for clients. And when you're dealing, with clients who are in a marginalized population, face a lot of challenges, there's a lot of additional things that come up when providing telemental health services. A lot of the clients are experiencing things like poverty that limit their access to technology and the things that they need to access those services. And so in addition to kind of that pivot to providing telemental health services, CMHA Ottawa also, was thinking about, well, how do we facilitate access to our clients? And so they started an initiative where they provided mobile phones that also included mobile phone plans to help their clients in accessing those telemental health services. And at the time that this evaluation took place, I believe they had handed out over like 150 phones to clients. Yeah, and so that brings me to our goals. So really our main goal of this evaluation was to get that like in-depth understanding, both from the perspective of the case managers, but also of clients, of their experience with the phone handout and with the transition to having more services through telemental health. And we really wanted to focus on perceived changes, benefits and challenges, but also with coming up with some recommendations for CMHA Ottawa to improve their services and what they want to do with their services, moving through the pandemic. And so for this, we conducted semi-structured qualitative interviews. And so that means like we set up an interview guide with questions ahead of time that focused on those key areas. We also provided a lot of flexibility to participants to focus on what they thought was really most important, or even kind of bring in ideas or topics that we hadn't initially considered as researchers, which is really important for kind of getting that in-depth perspective. We had 11 case managers who participated and 9 case management clients. And so I'm not sure if anyone who did participate is present today, but if you are, I just want to say a huge thank you. And then we also collected some administrative data. So this is on things like client characteristics, but also some admin data on the frequency and length of phone versus face-to-face contacts. And then for our analysis, for the admin data, we presented that descriptively, and then we did a qualitative analysis of the interview data where we looked at themes, similarities, differences across interviews, and synthesized those main findings. Yeah, so first I'm going to talk for our findings, talk about the perceived impact of the phone handout itself and its benefits and challenges. And then I'm going to move into talking about like the transition to telemental health services a bit more broadly. And so for the phone handout program, really the primary benefit that people talked about was that it allowed clients to access services, both through CMHA and also other services, while those in-person services were limited or not possible because of COVID, and also during a period where there was a really high need to continue to access services. And then the phones also improved case managers' abilities to find clients, especially certain clients are more difficult to find. So that was commonly reported as a benefit, to set up those in-person appointments, to maintain contact, and to check in with clients. And clients also reported it made it easier for them to kind of reach out and get support from their case managers. But an important thing that came up in this study was actually we noticed a lot of benefits even outside of like direct case management service delivery. And so outside of that, like clients were able to access support from like friends and family and maintain those relationships and access other resources. And it also really promoted client independence and autonomy, and allowed them to do things like set up their own appointments, like look for housing, because they now had that ability to do that independently. And so I have a quote here from one of the case managers who participated saying, for him, it's been life-changing with the relationships he's been able to develop with his family and friends, and with where he is now versus pre-COVID. So just talking about the profound impact that just having that phone had on this client's life. But that doesn't mean that the handout program wasn't without its challenges. And the main challenge that came up from people was phones being lost, being damaged, being sold, or being stolen. And actually a few clients who participated talked about their own direct experiences with having a phone lost or stolen. And another challenge that came up frequently was for clients struggling with psychosis and paranoia. It could be very challenging for them to have a phone and worries about being tracked and things like that. And so in general, what we found was that clients who were in more stable housing situations and also more stable in terms of their mental health were better able to kind of hold on to those phones and benefit from them. So then in terms of like case management delivery, more generally, there were a few main areas where there was changes. So one of them was the meeting modality, also meeting frequency, length, and focus, and then some changes in terms of privacy, and then also driving clients. And so, especially like very early in the pandemic, because there was these requirements to wear full personal protective equipment, but at the same time, there was just such limited access to that equipment. Almost all the meetings during that initial period were done by phone or through video conferencing. And 4 of the clients who participated described moving mainly to those phone meetings, and 3 described shifting to primarily video meetings. And one of the case managers who participated noted that they were already working quite a bit with clients over the phone. And so as a result, the pandemic didn't shift things quite as drastically for them, already had clients who were kind of used to working in that way. And then as the personal protective equipment became more available, case managers were able to meet with clients in person more often, but just needing to wear that PPE, needing to meet outdoors, maintain physical distancing, you know, the risk of exposure to COVID, these are all new challenges for providing in-person services that weren't present before. And the majority did continue meeting over the phone or over video conferencing at a higher level than before the pandemic. And so the majority of clients who participated reported that they were having either an equal amount or more contact with their case manager, with only one of the clients reporting less contact. And some of the reasons that clients gave for this increased contact included having reduced barriers to attending appointments and also just needing that social support because of the COVID-19 pandemic. And then participants also noted that phone contacts tended to not be as long as in-person contacts. And some people use them a little bit more as those like quick check-ins and reminders as opposed to doing that in-depth work, but that wasn't necessarily true of everyone. And so some people reported that the focus of the meeting stayed the same and there was no topics they felt either more or less comfortable talking about through telemental health. But for some, there was a shift away from that more like hands-on work, that more practical work, like for example, things like prepping documents towards appointments that were more focused on talking about personal experiences and feelings. And so as some of the results of the admin data presented here, so the data doesn't differentiate between like, it considers video conferencing to be a face-to-face meeting. So it doesn't differentiate between like telemental health and in-person, but it does support that the phone contacts have increased since the COVID-19 pandemic. So we have the phone contacts over here, like the number of contacts and the sum of hours. And you can see like right after the pandemic and then even maintained to almost a year afterwards, there's kind of an increase in those phone contacts. Oops. And then here it just shows that the average time of phone contacts did remain lower than the face-to-face contacts, and it didn't change very much kind of over time. So another thing that came up was privacy concerns related to telemental health. So one client was talking about concerns related to, Zoom, hearing that it wasn't necessarily the most secure platform. Someone else lived in a small space and found it difficult to find like a private space to have those meetings. Another one actually had the opposite experience, that only previously had access to a common phone. And so having the phone actually gave a lot of privacy because they were then able to participate in these meetings from the privacy of their own home. But there were even some new privacy concerns that came up in terms of like in-person meetings because of the need for PPE, for physical distancing. You know, you end up speaking loudly in these like outdoor public spaces. So that's something that came up as well. And then 8 of the case managers who participated said that a major change that came in with the pandemic was not being able to drive their clients anymore. And so this was used often as a casual way of, you know, like building rapport with clients, like driving them to appointments and stuff like that. But obviously with the COVID-19 pandemic, that wasn't possible anymore. And so that was another change. And then in terms of changes to the relationship itself, most of our participants reported that the quality of the relationship didn't change with the transition to having more telemental health contacts. And some of the clients actually reported that the relationship improved. And some of the reasons for that were just more frequent and easier contact with their case manager. And then another common theme that came up was that moving to more telemental health contact didn't have an impact on the quality of relationships that were already strong, but it was more challenging to build those new relationships and to develop trust. And the phone in particular posed challenges for that feeling of connection. And many participants did report that video conferencing helped overcome some of those challenges by allowing you to see things like body language, facial expressions. But it also posed its own challenges with technology and not all clients, you know, being willing to or comfortable using that. And I have a quote here from one of the clients just saying that they'd advise video more than phone because they don't really trust the phone as much. You can't see someone's body language. There's, you know, more of that connection with video conferencing. So finally, this brings us to the recommendations. So one of the major things that case managers and clients brought up was just continuing to provide access to phones and to phone plans for clients because of, you know, it facilitating case management, but also just the benefits outside of that as well. Also implementing strategies to prevent those lost, stolen, and damaged phones. And some of the things brought up there were things like, you know, getting OtterBox cases or using apps like Find My Phone and things like that. Yeah, everyone or most people agreed, you know, they wanted to continue to provide telemental health moving forward beyond the pandemic, and found there were a lot of benefits to it. Some other suggestions were providing the option for older technology to some clients who might not be comfortable with a smartphone, for example, and it could also potentially reduce the probability of things being stolen. And then preloading phones with required software and also resources just to facilitate that, make things as easy as possible for clients. So sorry, I realize I'm going over time a little bit here, but yeah, just in general, the conclusions are that the phone handout, it really facilitated access to telemental health services for some clients, but there were barriers that continued to exist for others. In addition to providing access to services, the phones also had, you know, benefits outside of that, including increased access to social support and promoting autonomy. And in the context of case management, our findings suggest that telemental health, it does offer a lot of advantages, but it does pose challenges, including technology-related difficulties, interactions feeling a bit more artificial, and also limitations in terms of the types of services that can be provided through telemental health. So thank you so much, everyone, for your time, and I will stop my share now. And yeah, I look forward to answering any questions that I get in the chat.
Thanks, Kim. I think there are a few questions for you in the chat, so you might have a look there, but we're going to move on without a buzzer going. And so I wanted to introduce Lisa. He is a University of Ottawa medical school student that we have. And University of Ottawa has this great program as part of their medical school program. All first-year med students have to complete a 30-hour placement with a community health agency. And for the past several years, we've hosted these placements. So this winter, we had 3 students, and 2 of them are presenting their placement work today. So Lisa's presentation is titled Action Plan for CMHA's Use of Telemental Health Services, Recommendations for Implementing a Hybrid Model Post-Pandemic. Take it away, Lisa.
All right, hi everyone. Let me just share my screen. All right, can everyone see my presentation and not like my presenter view? Okay, perfect. So thank you, Donna, for that introduction. So today I'm going to be presenting my work through the community service learning placement. And I'm really excited to be here and to share what I did. So starting off, I'll start with just some background about my project and how it came to be. So I chose virtual care because it's such an interesting and relevant topic right now, but it was a super broad topic, so it requires some narrowing down initially. So I spent the first few days and weeks looking at some papers that Maryann had sent me, and one of them was actually the research by Kimberly Turner. So I'm really glad that I'm presenting right after her because I feel like my work sort of built off of hers. I was really fascinated by that CMHA phone handout program and some of the benefits and the challenges associated, which I've gone ahead and shown on the slide. And so to me, it made me think about how can we use this information to then come up with a hybrid model of care to maximize these benefits while addressing these challenges. So that's how my project came about on hybrid care decision frameworks and also some training considerations that are related. And so in total, I looked at 3 hybrid care decision frameworks. So now I'll go through the main findings of each one. So the first one was called the Digital Health Equity Framework. And this was introduced in a paper by Crawford. And the reason that this model was created in the first place was because an unintended consequence of virtual care services is furthering the healthcare inequalities that already exist in our society today. So just as with in-person services, you need to consider social determinants of health and various factors like socioeconomic status, cultural context, and other individual factors. But when it comes to virtual care, there's this added element of additional digital determinants of health. So things like access to resources and digital health literacy and beliefs and values and cultural norms all related to technology. So for example, someone who's limited by poverty might be unable to access technology or not be familiar with technology. And as a result, they're not able to take advantage of these virtual care services, further perpetuating their lack of access to services. And I think we even saw this in that CMHA phone handout program with some of the lost and stolen phones. It felt like the people who sort of needed the phones the most. So for example, people who had the most unstable housing conditions or just the worst mental health conditions seem to have the hardest time holding on to these phones and actually utilizing them. So I think that just goes to show that, you know, these virtual care modalities can really perpetuate this lack of access to services and further these inequalities. So this is the actual model from that framework. So again, it goes over different factors that you need to consider. So social, economic, and cultural context, and then intermediate factors shaped by that context. And then of course, that added piece, which is the digital determinants of health. So I wanted to include this model because I think it's really important to take all of these things into consideration when coming up with a hybrid model of care. So the second framework that I looked at was from the Provincial Geriatrics Leadership Ontario Task Force. So they created a decision toolkit related to the use of virtual care and what modality to use for a visit. So the toolkit begins by summarizing what can be assessed virtually versus in person. So I've listed them on the slide here, and I'll just draw your attention to the fact that mental health was listed as appropriate for virtual care, whereas unstable mental health and emergencies were listed as inappropriate. The toolkit then goes on to show some potential risks and benefits of using virtual care and in-person care. So they're listed on the slide. I'll give you a second to look at it, but I'm not going to read through all of it. And these potential harms and benefits are going to be used in the next part of this toolkit. So the next part of the toolkit is this risk matrix. And I think this is the most important part of this toolkit. So essentially the risk matrix works by considering the likelihood of a consequence, as well as the severity or the impact if that consequence were actually to arise. So for example, something that's highly likely to occur and also with severe consequences would be deemed high risk, whereas something that's unlikely to occur and also with mild or low consequences would be deemed low risk. And so you can use this risk matrix to sort of evaluate each individual patient's situation to determine the ideal makeup of their care and to provide individualized services. So what you do is you start by making a table of potential harms for both in-person and virtual care, just like I've shown on the previous slide. And then you would evaluate the risk score for each potential harm. And then step 3 is you consider what changes can be made to modify the risk. So is it possible to remove the risk altogether by implementing some changes? If it's not possible to remove it, is it possible to at least reduce the risk, or do we have to retain the risk as is? And then finally, you would go ahead and calculate the total risk to compare the in-person and the virtual care in that specific situation. Now, of course, this is it would be like a very tedious process if you did it for every single patient and every single risk. But I think it is just a very important and useful tool for a basic, risk-benefit analysis. And I think it's really important to think about when you're trying to weigh like the pros and cons of virtual care and when you're trying to decide the makeup of an individual's care. And then the third framework I looked at was from the Heart and Stroke Foundation. So they came up with a stepwise virtual care decision pathway, although they do note that some of the steps can be considered simultaneously, so it doesn't have to be like in order, like just each step at a time. But essentially there's 5 stages. So the first stage is readiness. So this is looking at sort of, is there the technology and the infrastructure in the first place to make virtual care even happen? The second stage is initial triage. So is it possible to achieve the main purpose of that visit using virtual care? The next stage is appropriateness. So this is looking at factors beyond the initial triage. So like the complexity of the case, the urgency, just like other factors and needs of that client. The next stage is safety and risk. So considering what other risks exist and whether they can be mitigated. So kind of relating back to that risk matrix that I just discussed. And then finally, modality selection. So choosing the most appropriate modality for that situation. And then the framework also discusses 5 core elements of virtual care, which I've listed on the slide as well. So these are just different factors to think about alongside the pathway. So from individual factors to like system and environment and organizations, et cetera. So just looking at it from different levels. And also considering, I guess, some of that health equity stuff that I mentioned in that very first framework. So the next, so this is the actual framework from that study. So again, the 5 stages in the middle, and then the different elements listed on the side. And then of course, continuous evaluation, monitoring, and feedback is very important just to make sure that things are running smoothly. So the next part of my work, I decided to look at some training considerations because I think training is a really important piece in order to appropriately implement an effective hybrid care model. And so what I found was that there are a few areas where additional training would be really beneficial in the switch to like a virtual care hybrid model. So the first one is safety and security. So this refers to things like privacy issues, so protecting data, recognizing safe environments for digital care, but also addressing other risks and threats just with the use of technology. So even things like eye strain, musculoskeletal issues, and like mental health concerns like paranoia, for example, these are all things that should be considered and that should be talked about in training. Next, communication skills. So it's important to know how to interact with others using these online tools and using culturally appropriate communication methods. So I think training on just the different modalities and etiquette and stuff like that will really help to avoid misunderstandings and miscommunications with the use of these virtual services. Next one is technology and problem solving. So this is pretty self-explanatory, basically knowing how to use the different technologies, the different platforms, and how to troubleshoot when issues arise. Next one, staff engagement. So studies found that staff engagement and motivation is really important for facilitating successful virtual care. So especially during tough times like COVID and during times of change, like transitioning to virtual care, it's just important to kind of use creative methods and to improve morale and to keep staff supported so that they can then go and help their clients. And then finally, availability of training materials. So having access to these resources, making sure that clients and case managers know where to look for support if needed. And I guess along with this would be just like further investments in training to make sure that case managers feel well equipped to deliver the services. So in summary, I talked about some of the benefits and challenges associated with virtual care. And then I looked at 3 hybrid care decision frameworks. And I think some of the key takeaways were that, one, there's just many considerations when creating a hybrid care model, from individual factors to social factors. It's also important to use like a methodological approach. So like in that Heart and Stroke Foundation decision pathway, it's also important to consider the determinants of health and that additional digital determinants to help avoid the increasing gaps in healthcare inequality. And then finally, doing a risk-benefit analysis is really useful. And then I talked about training considerations, and then I just wanted to quickly mention that quality assurance is also really important. So again, monitoring and tracking the data for issues and just doing further research. And I think it would also be helpful to involve people in marginalized and vulnerable groups just to get their input when creating a hybrid model of care. And then I'll just end really briefly by just quickly mentioning, I really enjoyed my community service learning placement. I learned a lot, and I'm pretty happy with the final project, which was actually an action plan that I made that basically summarizes all of my findings. So thank you so much. I will stop sharing now. All right. And I will pass it back to Donna.
Thank you, Lisa. That was great. Something's wrong with my computer here. Anyway, fabulous. So our second medical student is Merelle Tadros, and she's presenting her findings from a review of clinical decision support literature for community mental health setting. So take it away, Merelle. There you go. Thanks.
Thank you, Donna. I will also just be sharing my screen. So as Donna has mentioned, my role with Maryann was also to review some literature. We specifically focused on clinical decision support, and we focused on adolescent mental health. Oh, sorry. Let me. So I wanted to start off with a general understanding of what my literature was meant to revolve around, which is clinical decision support. So it's important to understand a definition and have a clear focus of what we were trying to get at for the purpose of the presentations. So clinical decision support is essentially providing clinicians, even patients or individuals, with knowledge and person-specific population information. So this is essentially something used to better patient care and population health overall. And this is something to aid clinicians while using to make proper decisions with all factors incorporated. Our focus within this definition was to foster better health processes and overall better population health. That's what we were trying to get at while reviewing this literature. So initially, before starting the project, we had thought that in the medical field, so in established hospitals, there was a broad understanding and a sound application of clinical decision support, both at the patient and system level. So within hospitals, we figured that since they are pretty established, that they would have a better understanding of how to use these decision support frameworks. But in community mental health settings, the identification of these components weren't as established, and a lot of things weren't as standardized. So most of the literature on these clinical decision supports focused on the medical aspect or the medical services like primary health care and various hospitals, but not so much on the aspect of community mental health and addiction services. So that was our mindset going into reviewing the literature. We have found and identified a couple of other things that I'm going to go through with you guys today, but our abstract that I had wrote up, our background was to cover preclinical and clinical research that would present or suggest clinical decision support systems having a very wide and useful benefit for youth mental health. And that was the population we chose. So we conducted a scoping review, and we looked at a couple of articles. We have some methods where we specified date, we specified search terms, primary and secondary ones that I'll talk about a little bit more. And to conclude, we found 22 articles that we thought were extremely relevant and we wanted to share. But further research is definitely needed on this topic for policy makers and practitioners to be able to understand how to use clinical decision support systems and how they can be most effective within their use. Our purpose to expand, the main goal was to assess the extent to which the literature documented clinical decision support frameworks. And we wanted to see the impact, like the benefit, the pros, the cons that these things had on a community mental health placement, as opposed to medical services or primary care hospitals or clinics. So we selected a couple of search terms and figured out the eligibility criteria, and I've identified them on this screen. So we looked at journal articles, book reviews, or chapters. They were between 2000 and present. Our focus was on child, adolescents, and youth mental health. We had explicit exclusion criteria. So things that we did not really want were case studies that weren't as generalizable, because we want to see the most maximum benefit we are getting from these clinical decision support systems. Anything that was too IT focused was also excluded, because we want to see how these systems benefit the healthcare providers and the patients, as opposed to finding the details about how the system works. And anyone out of the age range, because we were focusing on youth, was excluded. So we looked at a couple of databases, and our search strategy included primary search terms, where we focused on more broad definitions like decision support team, clinical decision support, management decision support. And the secondary search terms were a little bit more specific: adolescent mental health and community mental health. So these helped a lot while filtering through a lot of the articles, because Maryann and I came across a lot of articles that seemed could have been relevant, but when you looked at them a little bit in closer detail, they weren't as relevant. So that definitely helped out a lot. This is a table depicting how our search strategy went. As I said before, we've excluded a couple of papers, and we were left with 22 that I'm going to be reviewing some with you now. So our key findings of the study in Kopsov et al. First identified that this is a big need. We need clinical decision support systems to help with our decision-making processes. So that was something identified. And then in Green's, his paper, they've sort of concluded, and in this image, I really liked it, so I wanted to pull it, that to approach a clinical decision support system, what might be useful in helping is not one sole aspect. It's an accumulation of a couple of things. And in the yellow boxes, you can sort of see the aspects or the factors that can go in to impact a clinical decision support. So there's quality improvement aspects, there's health system priorities, cognitive tasks, things to be supported, knowledge management, and a bunch of other things. So it's just important to understand that not one thing will lead to a good system. In Ostroff et al., building on that, they've identified various chapters in their book that was essentially a building block to have a successful program. So you need to have a broad understanding of these systems and their toolkits. You need to have a documented plan, a good assessments for decision making, and understand and improve the system's workflow, see what works best and what doesn't. And then finally, they identified that they need a way to acquire, validating, and updating these contexts, because throughout our times, everything changes based off where you are, your environment, and those things have to be taken into account. A couple of other papers that I would like to share sort of identified referral systems. So these papers talk about very similar things, but they all have a specific aspect to them. And that's what I wanted to sort of draw out. But Foster's paper sort of respected a natural logic and flow when implementing these systems. It wouldn't be as useful to come into a workspace and just change things around and not have good worker interaction. So it's nice when the system's friendly the system is friendly to use and there's organizational constraints. Ross et al. Identified more of a specific type of community decision support system. It was the IDs in Norway, and that yielded very significant results. So it was nice to sort of see their paper and outline some of the aspects that they had taken. In Woltman's paper, they demonstrated that if patients are involved in this process, in this clinical decision support system, in a sense, their interaction with their practitioners will be more beneficial and they will have better overall health. So always involving the patients inside the decision is very beneficial. Another image that I really liked from Clausine's paper sort of emphasized Wenderlust's as well. So they sort of saw that if guidelines weren't followed and things weren't formed in sort of a habit, like if there was no adherence, that things would fall through the cracks. And the reason why I really like Clausine's paper was it sort of showed what we're trying to really get at, that there's so many factors in the environment that can impact a practitioner's decision-making for a patient. And it brings it all together. There's like certain guidelines, there's news from scientific literature, practice parameters, what they can and can't do, health data, things about different patients. All of these things come together and help at the end of the day to sort of have a better real-time decision support system aid for practitioners. And it's not necessarily to replace a practitioner. It's just to aid them in their guidance to make a decision in real time, which is very, very crucial and important. So I wanted to outline that as well. Some other specific findings from certain papers were evaluation charts and other methods to sort of get at the same clinical decision support system, but finding specific ways to see what would be best. And there was information-based medicine, which is using knowledge that you've gathered to be able to incorporate that to the patient's care. Orstein's paper actually identified that these outcomes were more beneficial at a reduced cost, which is something else to be very mindful of. It's not that these systems are very expensive and unrealistic. If anything, in the long run, it will be more useful and practical to implement them. So it's better to start off having good processes now to be able to use them for the future. And that being said, similarly, a good scientific approach in primary prevention would be able to be taken into account as well. So to have a good system, there needs to be pillars established. For example, knowledge needed when available, adoption and effective use of these strategies, and continuous improvement of knowledge, as I was saying, how things constantly change. So in Ostroff, in a different paper that they've put together, they sort of saw the widely useful guidance of implementing these decisions to developers so that this could be used more so. And McDonald's paper sort of looked at a breakthrough series model, and they could see that over a year, there was a large learning and collaboration model being impacted, and this helped a lot. So there's a very large portion of education that is needed to be taken into account in here. And once that is done and got through the way, this will make a very big difference within healthcare and healthcare practices. So it's something that we should definitely establish more. Even though it might be a little established in hospitals and primary care clinics, in community settings, this is this also has to be much more sound to be as effective as we would hope it to be. Future direction, there was a lot that we've identified throughout this study. And I saw that we need to figure out which articles we would need to use for the paper. There were really nice ones that outlined various things, and we would just need to solidify our plan, and then lastly reflect on the various aspects of these clinical decision support systems, because there are many, and it's not, as I said before, there's no one right answer. So highlighting the pros and cons of each system would be very useful to pick out all of the highlights and be able to use that in one overall system. But yeah, thank you guys for listening. I hope that this was informative, and yeah, I'll pass it back to Donna. I'll just stop sharing my screen now.
Thanks so much, Merelle. I had to go get a coffee. That was so like stimulating for my brain, all that information. And I would just encourage other people as well. You know, that's the great thing about doing virtual settings, you know, to get up and move around a little bit. And so we don't get, what do they say, sitting's the new smoking? But I won't start talking about smoking. Okay, the only other thing I wanted to mention about our third medical student who wasn't able to join us today, Estelle Caron-Poulin, she had done, and this was would have presented in French, which would have been really nice, but she did a annotated bibliography for us on measurement-based care in community mental health settings. And I think for a lot of us, that's something that we're hearing a lot of. And so just to let you know, that will be included in the summary proceedings as well. Okay, so on to our next presenter. Here we go. I have a cup of coffee and I get all mixed up. Okay, so our next presenter is Ayda Agha from the University of Ottawa, experimental psychology PhD candidate. And she's presenting CMHA Ottawa's condo program, case study findings and toolkit. And we also have Leif Harris here. Morning, Leif. He will share some of his experience with the project as well. And as part of their presentation, they will also share a knowledge mobilization video that was developed with the University of Ottawa's Centre for Research on Educational and Community Services. And the video features Leif, Stéphanie, who spoke to us earlier, and our own Lisa Med, who's our housing manager here at CMHA Ottawa, who's on her first day of holiday. So we wish her fun and wellness on her holiday. So take it away, you guys. Condo program.
So thanks, Donna. So I'm Ayda. So I worked on this project with Maryann, Stéphanie, John, as well as Tim, who is our supervisor, who isn't here today. And then we were actively working with Lisa and Donna herself throughout the project as part of our collaboration. And then Donna did introduce Leif. So hi, Leif, it's so great to see you. So Leif was a tenant, a researcher, and kind of a stakeholder that was heavily involved in our study throughout the process. So he participated initially in the first pilot interview and helped us develop our interview protocol for the tenants. And then he was actively involved in the tenant meetings. And now he's been working with our team as part of the knowledge translation and mobilization. So I'll share the video once I've kind of presented the project itself. And then Leif, you can take it away at the end if you have any thoughts or anything you want to share as someone with lived experience. And it was so wonderful to have him with the project. So let me.
And I for one thing I should mention as well that as well as being an advisor to the project, Leif is also a Carleton University Anthropology Honours student. So he's wearing a couple of hats here today.
That's awesome. Okay, so we did an evaluation of, I guess, what is known as the CMHA condo program. So this is a housing first program that CMHA kind of developed throughout the past couple of years, almost like more than 10 years. So I'm just going to quickly kind of give a little bit of a brief background for those of, oh no, how do I go back? Oops. For those of you who are not familiar with Ottawa, so compared to cities like Toronto or Vancouver, Ottawa is kind of known to be a little bit more affordable. But even despite that, approximately about 1/3 of Ottawa households are renting, and 41% of renters are paying above the affordability threshold. And so the low vacancy rates and rising costs of rent that have probably gone even worse do contribute to long lists for subsidized housing, especially for those programs such as Housing First. So as many of you might know, CMHA is a Housing First agency, and they do provide private market units, case management and rent supplements to clients with histories of homelessness. So in 2002, so more than 20 years, CMHA launched what is known as their Housing First condominium program. So they purchased about 22 condominium units, and then they rented these to clients with serious mental illness and those experiencing homelessness. And since 2002, the program has grown with, I think, 40 units. I'm not sure if that has been expanded yet. I know there was talks to purchase some more units. But as when we were doing the evaluation, it was approximately 40 units. And the funding was afforded through government funding, so through the municipality and provincial governments, as well as affordability grants. And then the maintenance and renovation costs are covered by a revenue stream that comes from a budget within CMHA. And then tenants are offered rent supplements, and the units are exempt from property taxes. So the purpose of our evaluation was to do an outcome and implementation evaluation. And our main goals was to kind of determine the extent to which the program itself is aligned with Housing First. What are some of the challenges in implementation? And then how does the participation in this program improve housing stability and quality of life for tenants? So we did about 13 interviews with tenants who were living in the CMHA condos, and people were living in there for different durations of time, some of them for more than 5 to 10 years, others who had recently moved in. We also did a focus group with the case managers, and these case managers would have both Housing First tenants who were living in condos, as well as those who were living in the private market housing as well. And then we also did key informant interviews with the program staff, funding, property managers, and the condo board members. And then finally, some literature reviews, document reviews, administrative analysis, and so forth. So I'm just going to go straight into the outcomes and what we found. So we did find that the project was, or the program was very in line with Housing First principles. So the ability to provide immediate scattered site housing, there was no sobriety or treatment requirements, there was access to housing and social support, and the landlord and support roles within the same organization was clear. So one of the Housing First principles is the separation of landlord and support, and the CMHA was able to effectively do that by separating the housing coordinators and case management roles. So even though it was within the same institution, they were able to kind of separate those as well. And so if there was cases of evictions or changes or issues like that, the housing coordinators would work on that, and the tenants would maintain their case managers and support workers, regardless of whether or not they were in the housing or not. Another thing that was very interesting that CMHA liked to do or started doing with their later duration of the condos, which kind of facilitated housing choice, which was also kind of a principle of Housing First, is that with the purchase of the new condos that they were looking at the time of the study, the tenants were actually, or the potential tenants who'd be moving in were actually involved in coming and viewing the properties. And that just kind of, you know, fostered housing choice in a sense of autonomy, and just kind of gave them a little bit more involvement in the choosing of where they're going to be living. So I thought that was something that was really interesting that doesn't often come in the private market housing. In terms of some of the implementation challenges, the caseworkers talked about some of the clientele that's aging and some of the limitations due to that, whether there was lack of stairs or elevators and issues with disability like that. some loneliness and isolation, which is very common in Housing First, adjustment to independent living. There were some experiences of discrimination and exclusion, sometimes from neighbors, but it seemed that also over time, participants did kind of integrate into or tenants did integrate into their communities. And then there was issues of vulnerability to home takeovers and some cases of evictions. In terms of the program level challenges, heavy case manager workloads, some of the issues related to prices of condos in accessible areas. So there was not that many different neighborhoods that would have condos that could fit the requirements. And then another challenge was kind of managing and maintaining like repairs and renovations. And one other issue was the non-transferability of rent supplements. So if they were going to move from a different unit, being able to take the rent supplements with them. And then finally, the inability to leverage equity from the units. So there were some units that had been fully paid off or been bought out. And so they were not able to kind of leverage that in order to find new condos. And I think Lisa might, I guess she's not here today, but she might be able to kind of update us on that, or whether or not that has changed since we conducted the evaluation. In terms of outcome findings, so we found high satisfaction among tenants. Majority were kind of satisfied with their property, neighbors, and neighborhoods. Some tenants did feel like the location was a little bit far out in terms of not being close to downtown and resources and amenities, but for the most part, we kind of found that they were satisfied. Housing stability was also another outcome. So tenants could stay in the condos even if their case management ended. Tenants described in the interviews feeling as peace, knowing that their units would not be taken away. And then units were also held. So if a tenant was incarcerated or hospitalized, they did not have to worry about losing their home. We also noticed just general quality of life improvements for tenants in terms of physical health and mental health. A lot started going back to school, obtaining employment. They described feeling in control, freedom, independence, and a lot discussed plans for the future in general outside of school, connecting with family and so forth. And then one other aspect in terms of our outcomes was housing quality. So the case managers and tenants did kind of report that the quality of housing in the condo units was higher than those in the private market. So those who were part of the Housing First program, but were in private market units. And a lot of this was because the CMHA was responsible as landlords for the maintenance of repairs and renovations. And even the newer units that were being bought were renovated prior to tenants moving in. So they were kind of able to control the housing quality in terms of being able to access the units and kind of if there was issues, whereas in the private market homes, the landlord would be a separate person. And so they were not able to kind of address those issues for those tenants. So what are the main implications? So the program was successfully able to create affordable housing for Housing First clients. We actually found that it was able to foster positive landlord and tenant relationships. As a mental health agency, CMHA is kind of able to kind of meet the landlord role better because they're familiar with mental health and physical health issues that some of their tenants would be facing, as opposed to private market landlords who might not have the background in those areas. We also found high levels of housing security, housing stability, and general community integration for clients. Just the ability to provide higher quality housing. And the program can be applied to small rural areas and urban communities. And we did develop the toolkit that I'll share the video for after this. So if there are other organizations that would be interested in kind of following or doing something similar, they're able to kind of follow our model. So I guess I'll share the video and then I will kind of let Leif take it away or kind of share his experience. So just give me one moment in terms of. Sorry, 1 second. I'm having some trouble finding that. There it is. So there's Stéphanie, who has put together the video with Leif and Lisa, and I'm just going to press play. Can you guys hear it? Are we hearing it?
We can hear it, Ayda. Yeah.
Okay, perfect.
In terms of what it means for me, mostly it means opportunity. Because since I got here, I managed to do a lot of different things that I'm really proud of now. Like I've gotten a job in the first 2 weeks of moving in.
What is the CMHA condo program?
The CMHA condo program is a nonprofit housing program that is really based on the fundamentals of housing first principles. So this program has been in existence since 2003. The theory behind it is that scattered site independent housing for people with lived experiences of homelessness, mental health issues, and addictions, that they will recover and succeed best and desire independent housing. And so we were able, with funding back in 2003, to purchase 22 scattered site apartments in condos and set up individuals with this history of homelessness and mental health and addictions as tenants in these units. And since then, it's grown. We have 40 units now. And so we've been operating this program for quite some time, very successfully, and very happy to promote it.
We created the condo program toolkit, and the toolkit is a product of a larger case study where a group of us researchers from CRECS partnered with CMHA Ottawa to examine the implementation and outcomes of the condo program. And so the case study included interviews and data across multiple levels, including tenants, staff, and property managers. And the main goal of the project was to determine how the program functions and explore the program's reach, quality of housing, and tenant satisfaction.
What does the condo program mean to you?
The condo program means a few different things to me. First off, it means security, because it's geared to my income, so it's something I can afford. And if I don't make as much money as I normally do, then it's more affordable and easier to use. That's more the subsidy piece. The condo itself, I'm really thankful to be in here. I mean, it's really spacious. Before here, I was living in an 8-bed, like a house with like 8 other people. In terms of what it means for me, mostly it means opportunity. Because since I got here, I managed to do a lot of different things that I'm really proud of now. Like I've gotten a job in the first 2 weeks of moving in at a retail store, and then I ended up going to school at Carleton University. I'm in my 3rd year now. This wouldn't have been possible if I hadn't done this before. I worked for Schizophrenia Society of Canada. There are a lot of opportunities that have popped up since then because I found housing. If I didn't find housing, these opportunities I wouldn't have had access to in any shape, way, or form. So I'm really thankful for the condominium program that CMHA offers, because it's done so much for me in terms of my health. Like I've been able to quit smoking since I moved in too, and I'm clean off. I've been clean for a while, and I'm thankful for that. Well, I'm not saying it's because of the condominium program, but they're big support for me. I put in the effort, but they definitely helped out a lot. So I just wanted to say what it means to me is opportunity. It gives me a chance to do something with my life that I wouldn't have been able to do otherwise.
So this program, as Lisa mentioned, is based on housing first principles. So those include immediate access to permanent scattered site housing that have no requirement for housing readiness, a level of consumer choice and self-determination. It's recovery oriented, individualized supports, and social community integration. So as we captured the process of development and its strengths, we wanted to create this toolkit as an accessible document. So it separates from the academic papers that as researchers we would normally put out, and it's intended for use for the community members and organizations to seek as a guide and inspiration for new program development when looking to develop more affordable housing.
Our tenancy history has been really strong in it. So when people get housed, the stability of their lives is really, it really makes a difference. And this type of housing for most of our tenants has been exactly what fit for them and what has worked. And we see that in the long-term tenancies that we have.
what did you want listeners or viewers to remember about your creation?
I think we want to show and educate the community about one way that we can successfully implement Housing First, and a way that Housing First has been implemented in Ottawa successfully with CMHA. And it's important with the toolkit that we showed and created something that was accessible to community organizations to share about the program, the findings, and also how it can be implemented at a larger scale.
So Leif, if you wanted to kind of share any thoughts.
At Harvard Business School.
Yeah, I just want to reiterate what it's really done for me. I mean, 7 years ago, I was homeless. I was addicted to all kinds of things, and I wasn't feeling who I am. I wasn't feeling myself. I felt like I was a third person party. I refer to myself as Leif, and I wouldn't say my own name. But nowadays, in present day, you know, I'm going to my 4th year university now. I work for Schizophrenia Society of Canada, along with a professor at Carleton University. I'm going my 4th year. I do a lot in my community. I do judo. I do martial arts. It's given me, like I said earlier, opportunity, and now I feel like I have a chance at life.
Thank you so much. It's honestly been so wonderful working with you on this project and just being involved in this project. It was such an innovative, something so different. And it was just so wonderful to go and see people's homes and how much their lives have improved as a result. So kudos to CMHA for doing something really different. And it's been really wonderful sharing the findings in different contexts with the community. So thank you, everyone. If you have any questions, posts, but I think that's it from us.
Awesome. Thank you so much, you guys. Great to hear. And it is a wonderful program. Okay, so we're getting down to the last couple here. So our next presenter is Donna McGlinchey. Sorry, my eyes went cross there for a minute. Is a Master's of Science Victimology student at the University of Portsmouth. Now you might say, Portsmouth, where's that? Well, she also is the research manager for the Victimology Research Center at Algonquin College. And her presentation is called CMHA Ottawa Post-Vention Environmental Scan, Services in Ottawa Following Traumatic Deaths. And this is some research that we had asked to have undertaken to support the work of the post-suicide support team. So welcome, Diana.
Thank you so much for having me. And while I'm getting my screen share queued up, I also just want to thank CMHA for inviting us to collaborate on this. This was our first environmental scan, so it was learning both in terms of content, but also the process. So it was really beneficial to our team. So I'll get this going. Slideshow. I gotta move some heads around, sorry. I have a small screen. All right, here we go. Okay, so yeah, I'm gonna be presenting findings from a post-vention environmental scan that our team did in partnership with CMHA Ottawa. I also just want to acknowledge part of the broader team that I'm presenting on behalf of. So we had 4 Carleton University criminology students complete their placement with us, and they've drafted the report that we will be presenting to CMHA Ottawa. We also had a round of student editing from Haley, who is a victimology student who did her placement with us this most recent term. We've recently hired a graphic designer who's going to design the final work. She did not design this presentation. You're dealing with my less quality artistic skills here. And then also we have additional supervisors on our team. We have Ben Roebuck, who is the chair of our research center, and Carmen Hoost, who was recently appointed to the chair of the nursing program at Algonquin College. So for a bit of background, CMHA had approached us and explained that they currently have a program where they provide post-vention for community members who are bereaved by suicide, but they've recently had an increase in calls for providing that type of post-vention support following other types of traumatic death. So they reached out to us knowing that we conduct applied research to increase capacity for services that support victims and survivors. So together we decided to approach this by doing an environmental scan to see what's available in the community to make sure that we weren't duplicating work already done, and also to hear about what, if that work wasn't being done, what could CMHA Ottawa do to create a program that fit that need. So together we developed this research question: could CMHA Ottawa's expertise in postvention be more broadly applied to meet community needs? So to answer this question, we developed an online survey. It was very short, just 10 questions, and we had CMHA Ottawa circulate it through their professional networks, which gave us 66 responses, which was fantastic. I didn't know what to expect going in, and that was plenty, and lots of great, rich qualitative responses into our open-ended questions. And then we also conducted one focus group with members of the post-incident neighborhood support program. There was about 30 people in that group. And then the themes were very similar to the survey. We just got a chance to kind of ask more prompts, more follow-up questions to dive a little bit deeper into those questions. So in the survey, we heard from people from a broad range of services, which was fantastic because it gave us a lot of different perspectives about what people knew about what services were there, and also what gaps exist and what concerns might be. So I just made a few little bubbles here to illustrate all the different kind of mental health services, lots in the housing and homelessness sector, lots from community resource centers, some who identified that they work specifically in the BIPOC community, a couple of first responders. So really like a real good mix of folks that responded. In the intro, the preamble to our survey, we described postvention kind of being that like after an incident support, and then described how this could be used for other traumatic death, including things like overdose death. So we asked folks in one of the survey questions, are you aware of programs that match that description? And most folks didn't know of a program within Ottawa that matched that. So then we had a follow-up question asking about what available programs would you know of if this, if you need to provide support for someone who had experienced that kind of traumatic death. So 46 respondents listed several different options, lots of great ones in victim services, OPS, community health centers, and then 6 were not aware of any or only mentioned their own employer assistant or employee assistance program. So we had a lot of good discussion, especially in the focus group, about what gaps exist. And a lot of folks also took some time to write this out in the qualitative section of the survey. Primary ones being the language and cultural limitations, and the fact that a lot of current support is offered from a Western lens. There's also a lack of public awareness of available resources. So, folks just don't know where to turn to when they need that support. There's gaps related to outreach to isolated community members. And one of them that stood out to me in the focus group was like seniors who don't need ongoing support if they're living in an independent living type situation, but they might not know where they could go if they needed this type of support, if they had come across or experienced a tragic loss in their community. Folks also discussed inequitable access to services across the city. So even within community resource centers, they're just staffed differently. They have different options. They have different accessibility in terms of, like wheelchair access or other types of accessibility options. We were also told that adults without EAP have very few free or low cost options. And if those exist in the community, people just aren't aware of them. And then in terms of long waits, it was mentioned in our focus group that some of their clients are on a 3-year wait list for a social worker, and there's no interim support. So you're just waiting there, and folks don't know what to do while they're waiting if they experience a crisis or need additional support in the meantime. And then of course, pandemic related barriers, we talked about that, or we heard about that in previous presentations about people with limited access to technology. If things are only offered virtually and you don't have that access, then you're experiencing a significant gap. And then we also asked about potential concerns related to postvention, as well as the benefits it could provide to the community. A lot of folks talked about the harms that could be caused if services aren't culturally appropriate. So that came up quite frequently, both in the survey and in the focus group. In terms of benefits, there was a lot of good discussion happening about the support and validation for people who might not otherwise admit to themselves or others that they need help, but when it's offered in a group environment, it's easier for them to recognize, like, hey, it's okay to need this help. It also gives opportunities to connect. So, for example, in a workplace, you can kind of speak with someone who's going through the same thing as you and kind of make those connections and have additional support with your peers. One person in the focus group also talked about the long-term traumatic effects if you are, constantly experiencing these traumatic events. Having this type of intervention can lower the risk of that long-term impact building up over time. It also decreases stigma, which relates back to that support and validation, where when you see, a group receiving support, you can recognize in yourself that it's okay to be asking for that help. It was also interesting, somebody mentioned how this can proactively redirect rumors. So in a group setting, if you are directly, talking openly about, the cause of death or the cause of any other traumatic event, and you're speaking very directly about it, it can prevent workplace rumors that might circulate, and cause additional harm. And then a few people also mentioned how it can increase employee retention, because then employees feel like they have an employer that cares about them, like they're proactively making sure that everybody's taken care of. So based on the survey, our team has developed 8 recommendations. I know there's lots of words here. I'll just kind of skim over them quite quickly. So the primary one being that accessibility and awareness, like I had mentioned, folks don't know about this, or if they do, there's wait lists. Lots of services, especially with COVID, are at capacity. People who have to pay out of pocket face financial barriers to receive support. In terms of community-led programs, we talk about in our recommendations this internal growth, so building on what's already existing, and maybe if 2 different organizations offer similar supports, working together to grow those together rather than making 2 different programs that are similar. And that also helps build community solidarity, where different populations learn to trust each other and work together. And then we talk about the importance of including people with lived experience when these programs are being developed, just to make sure that they're being developed with that lens of based on people's lived experience. The use of group support, we talked about the benefits, like I had said in the previous slide. Group programming for the public kind of builds that community support and solidarity and breaks down barriers and stigma, and also offers that peer support where people can feel like they are speaking with someone who understands what they're going through. But then we also want to recognize the benefit of individual support and responding to pre-existing concerns that certain individuals within a community might have previous experiences that are individual to them, like if they've experienced trauma in the past and how this current situation might be impacting what they've already lived through. So making sure that you're addressing their unique or less common needs that might not be felt by the entire community, but are still important to address. And then outreach kind of ties back into that awareness in the community. So making sure that service providers know who to refer clients to, or know who to refer people to if they can't meet the needs themselves. And then we also talked about reaching out directly to populations who might not be comfortable might not be comfortable asking for help, but might still need that help. So making specific targeted outreach to those populations. And then I think one that came up frequently was Indigenous populations, making sure that you're making those connections. If they don't come to you, make sure that they know that you are there if they need you. In terms of this prevention for the community, we talked about, especially in terms of people who are bereaved by suicide, wanting to avoid the suicide contagion. So going out immediately and providing support immediately rather than having wait lists or having people have to wait and call in. So reaching out to those community members as soon as possible. And then for staff, making sure that there are free or low cost options so that staff aren't having to pay out of pocket when they need that support. And then training and service quality, we are talking about making sure that there's equitable services across the city, so that each kind of community hub has the same or similar support offered for, so that there's quality across the city, and that all training in those service deliveries are trauma informed. And then because this one came up frequently, we put this as a separate recommendation as well, making sure that everything is culturally and socially inclusive, making sure that that design is implemented at every stage. And then we've added just a few recommendations just from our perspective from the Victimology Research Center. So we are recommending that there be a formal evaluation of the current postvention program, just to make sure that it's meeting all of those community needs, and that when that program is being adapted or developed further, that there's an integration of trauma-informed care and consideration of equity, diversity, and inclusion. And then just a couple limitations to note about the study that we did. It was Ottawa specific. So we know that CMHA is a kind of a national organization. So some of these, some of the responses we heard are very specific to the Ottawa area. And we just want to make sure that the broader CMHA team knows that limitation. As well, some of our survey responses were not required, and many were just kind of a short form, 1 or 2 words. We did get some really rich data, but some responses just weren't as helpful. And we did one focus group, and I said there were 30 people in the room, but there were some folks that did more of the talking. I think we heard from maybe 6 people answered every question, and 2 or 3 other ones might have chimed in here or there. And I think, part of that might be that other folks were just kind of nodding along in agreement and didn't need to add more, but just to note that, most of those responses came from maybe between 6 and 8 people. And that's it for me. I've got my contact details on the screen there if you have any questions or want any follow-up. But otherwise, I'll stop sharing. Thank you for listening.
Thanks so much, Diana. That's really interesting information. And I know that post-suicide support team is really looking forward to receiving that document. Okay, our last presentation, and we're back to Maryann, who has graciously agreed to present on behalf of the student, Ariane Magny, who is the University of Ottawa Honours Psychology student, and is her 4th year thesis. She did an analysis of our length of stay for case management service at CMHA and predictions, identified some predictors for length of stay. So Maryann, go right ahead. This is really interesting stuff. Thank you.
Thanks, Donna. It's been so great to hear all the other presenters. So here we are. We've come to the end of the event. Like Donna said, I'm presenting on behalf of Ariane. If she had been here, she would have presented in French. Before I go into her study, I want to acknowledge the support of Lucy Whitaker in providing the data for this study. Lucy and Michael Whitaker are so supportive of these evaluation and research initiatives. Anytime in these presentations when CMHA admin data is mentioned, that's a flag for Lucy and Michael supporting the work. So thank you, Lucy. She provided several data sets for this study, and then it also helped to shape the analysis by answering our data questions around what sorts of analyses were possible. So we wanted to, in conversation between Ariane and CMHA Ottawa, we came up with this focus for the thesis. There is like I said, actually in my first presentation, the intensive case management is not a very well researched area, but the research that has been conducted shows that there are reduced hospitalizations when people participate in intensive case management, improved housing stability, and improved financial outcomes. And then also as background, there's general consensus that when people are in intensive case management, they can be graduated. And there's this idea that when people are closed in intensive case management, then there's an opportunity for others to come into case management. So people who are graduated, when they're ready, can be shifted to less intensive services or in other areas of their lives. So I want to acknowledge that this is a little I feel like it's a bit of a sensitive topic, so I hesitate to know even what term to use when talking about graduation from ICM. So sometimes we hear closure, exiting, moving on, or stepping down. I don't know if anyone wants to offer some suggestions in the chat box around how to speak sensitively about closures, but this is the topic that we explored for this study. So again, speaking to the research in ICM, few studies have examined length of time in intensive case management, the process of closing people in intensive case management, characteristics of people who stay longer in case management than others. Okay, I have some suggestions here. Curtis says graduation is kind of a thumbs up term. And then Courtney is suggesting transitioning. That's a good term too. Thank you. Okay, so there are a few studies that look at characteristics of people who stay in ICM longer than others. And then also a few studies looking at people's outcomes after they graduate from intensive case management. Speaking about the topic of client flow is quite prominent in community mental health right now. So how do we flow people through services appropriately, sensitively, still leading to good client outcomes so that those who need intensive case management can access the service. And this is a necessary conversation because of limited resources and long waitlist times. So again, because this was an honors thesis project, we needed to really focus in the analysis. So in the end, we focused on looking at characteristics of people who stay in intensive case management longer than others. So consider this as perhaps just one piece of the puzzle or a step towards understanding graduation from ICM further. The purpose of this study was to determine whether certain demographic or clinical characteristics could predict how long a person would stay in intensive case management. We used this model or this framework called Gelberg-Anderson's behavioral model for vulnerable populations. This is the model that's used, it's been applied in the homelessness sector, and we find it helps us just to frame projects if we have a lot of different variables going on. And the whole point of this model is to predict use of health services or use of social services. So we were looking at how long people stay in intensive case management. So that would have been what we were predicting, the length of stay in intensive case management. And the model organizes variables based on predisposing factors, presenting issues, people's diagnoses or needs, and health behavior. So all of these different areas or domains can be part of what predicts or what influences how long somebody accesses a service for or uses a service for. Okay, this is kind of a text-heavy slide, but we used several different analyses to look at characteristics of clients in intensive case management. One way that we looked at any CMHA Ottawa case management clients who were active clients from April 2019 to March 2020. And we chose this time frame just because it was pre-COVID. So we wanted to get a sense of a group of people and how they moved through service, but before the complexities of the pandemic. So we had a sample of 307 intensive case management clients, and we divided the group up for some of our analyses. And I'll just say that this division was not implying how long people should stay in intensive case management. It was more for just the analysis reasons. We didn't have enough people who were closed at 3 years or 4 years or 5 years. So we divided them up based on a 2-year time frame, but it's not implying that people should be closed after 2 years. So we had 178 clients who were open after 2 years of case management, and then 129 clients who were closed at 2 years or earlier. And we divided up our sample into those two groups, and we looked at differences between the groups. So first of all, we conducted t-tests and chi-squares to see if the groups were significantly different. So these tables are showing the significant differences. There are a lot of characteristics that were not significantly different, and that's a finding in and of itself that we can't necessarily identify who's going to stay in service for longer or not, and that's in a lot of ways a good thing. So we had for people who were still open after 2 years, they were older. They were more likely to be women. They were more likely to identify financial issues when as presenting issues when starting in service, or they were more likely to be identified as having financial issues. And they were more likely to have chronic physical health conditions. So those were characteristics that were more likely in the long-term and open case management group. And then we conducted a logistic regression just to look at these differences in more detail, and we found the same significant predictors. So if somebody was older, a woman, had financial issues as a presenting issue and chronic physical health conditions, they were more likely to still be open in intensive case management after 2 years of being in the program. And then we just had another analysis that looked at that was similar but different. So we looked at only the closed clients in that sample of 307 people. So at the time that we ran the analysis, 226 clients had been closed, and they had been in service for a wide range of lengths of time. So the average was 30 months, but some people had been closed after 1 month, and some people had been in service. I'm just looking at my year translation. So they'd been in service for a maximum of 194 months, which I think is about 16 years. So just looking at closed clients and looking at that range of time in service, we found that, again, people who were older were more likely to be in ICM for longer. Women were more likely to be in ICM for longer. People who had a presenting issue related to daily living activities were more likely to be in ICM for longer. And people with chronic physical health conditions were more likely to be in ICM for longer. So this is, again, like quite a bit of text, but so the study just begins to explore characteristics of people who are not closed in ICM after 2 years. And really what we're finding is that the groups that are being identified are groups that we know would have could have more complex needs or face more complex challenges, particularly groups who are homeless or vulnerably housed. So there might be more gaps in services being identified here, or especially when we look at the older population or people with chronic physical health conditions who are homeless. So what we're doing is identifying areas that could benefit from more focused supports. We could just be identifying people who stay in ICM for longer, and that's totally okay. The findings also continue to support CMHA Ottawa's approach to ICM in providing services that are personalized, that are focused on individual recovery goals, and a focus on on allowing for this flexibility, and then longer term care for people, especially people who identify with certain vulnerable groups. This focus is particularly valuable. So thanks everyone for listening to these findings, and apologies that Ariane couldn't be here today. She's a hospital social worker, so she had a good reason.
Thank you very much, Maryann. And yes, so that's our last presentation, and wow, I just what a terrific morning. Anyway, it's going to be great when we get our proceedings document that we'll be sharing. And I'm just going to turn it over to Todd Bridger, who's one of our colleagues on our decision support and accountability team. And Todd's our manager of quality improvement and quality assurance. And I'm sure he's been making notes about all the different ideas. We could do this and this throughout the morning. And Todd's going to sum things up and send us out. Over to you, Todd.
Thank you, Donna. So here we are. near the end of the day, but I like to think of it as not the end of it, it's the beginning of it. So before I say all the thank yous, I think that should be allotted to everybody's here. I wanted to give a couple quotes and for us to think about and to contemplate going forward. So the first one is, if you can't measure it, you can't improve it. And essentially today, that's what today's been all about. Right from the beginning, when Tim had mentioned, welcomed everybody to today's presentations, that you know, if we forget the past, we're damned to repeat it. And so why do we do, and there's a common thread that binds all of us. Why do we do this? And why are we here today? Is because we care about the people that we provide services to. And we want to ensure that we're providing the best services possible and continuously improving upon those services. So throughout the day, we had presentations, research presentations that were both quantitative and qualitative. You know, whether we're looking at reducing wait times or substance use or individual's perception of care, it's all extremely important for a lot of well-documented reasons. And so as we go forward, the second quote is, knowledge is like money. To be of value, it must be circulated, and circulating it can increase in quantity and hopefully in value. So that was a big part about the philosophical underpinnings of today. That it's one thing to have the knowledge, but to hoard it means nothing. And if we share it, then we build upon it. And we often hear things like evidence-based practices, and you heard about a fidelity review on the Housing First program, and how we know that the closer we are to that established best practice, the better the outcomes are for clients and individuals we serve. But there's also something referred to as emerging or promising practices or emerging best practices. And so if we transfer the knowledge, not only do we provide increased capacity, but we also provide capacity for people to look back on what's been done before to continuously improve upon what we're doing today. So to that extent, I'd like to say farewell to everyone, but give a big thank you to all the students that presented today. I also like to thank Donna Pettey for having this close to her heart for the 22 years that I've worked with her. And I'd also really like to thank all of our CMHA partners and community partners and the consumer advocates and advisors that are with us today as well. Because again, it's a common thread that we care about the individuals we provide services to and the quality of service that we provide. And we owe that to the clients and their families. So thank you, everyone. And we hope you have a wonderful lunch.
Thanks, Todd. And you will receive an evaluation from our education team as well. Mm-hmm. So if you can, because we have to measure it or it doesn't count, you know, and also the proceedings will be coming out as well. So thanks very much, everyone. Have a great weekend. Bye-bye.
Bye.